Hi, team. This is Brandy from Mana Health Partners, and there have been some questions about documentation over the last several weeks. Allegations of abuse, resident to resident interactions. And so I wanted to just go over what our portion of documentation should consist of, what we don't want to regurgitate a whole bunch of unnecessary information. We want to keep it short, sweet, appropriate, and practical for whoever is going to be reading this. So first is the resident to resident altercation. That's what I was asked to do first. We've had several of those. You've got two people involved, usually the aggressor and the other person. Now, the other person could turn into an aggressor as well if they are both aggressive with each other. But let's just take the aggressor, who is the person who initiated the incident. Now, it can be a verbal or a physical. They can be on the other side of the curtain and scream obscenities or degrading things to their roommate, or it could actually be a physical altercation. So, key charting elements. First, you're going to want to make sure that it's without a doubt noting that you were not present for the incident. Confirm resident safety and absence of acute distress or injury. So that's when you go in the following day or the following afternoon and make sure that the resident is safe and that there's no acute injury or distress noted. Any complaints of pain, follow up with a x-ray. Anything that looks abnormal, follow up with that. That's you assessing the patient during that time. Document behavioral and mental status at the time of your exam. So the person's alert and oriented ×3, and at this time he appears to be inebriated. You're going to document that mental status. Not that he appears inebriated, because you're not able to document appears, because then that's your prejudice in there. But you're going to document that mental status. And then if the patient is at baseline or exhibiting increased agitation, so the patient's normally alert and oriented ×3, and now this is something that's very out of the ordinary for him. Specific interventions, anything that they had initiated, PRN medications, redirection, care plan review, and you are going to do the same as well. You're going to document this. So this again is your documentation. And then you're going to indicate ongoing monitoring and whether psych or behavioral consults are in place. So no matter what, if you're talking about a resident to resident altercation, you will always involve psych so that they can do their section of the investigation. So the aggressor, the resident, this is just a blip that you're going to put in his medical record as far as his HPI. The resident was evaluated following notification of an incident. The nurse practitioner was not present at the time of the event. At the time of assessment, the resident appears alert, is not in any acute distress. No injuries are noted. Resident is at behavioral baseline and cooperative with redirection. So orders for ongoing behavioral monitoring and environmental modification remain in place, and no medication changes are indicated at this time. Care plan reviewed and updated to reflect incident. Nursing staff will continue close supervision. So ongoing behavioral monitoring, environmental modification. So they might have removed the patients from each other. They might have separated them, given them a different room. The one that was the aggressor may be on one-on-one at that time. But you see how this does not say anything specific about the incident, just that you evaluated the patient, you weren't there at the time, and based on your evaluation of how you see him now, there's no injuries. He's at his baseline, and that we're going to continue to do whatever was implemented before you got there. Here's another one for the aggressor. This resident was evaluated following notification of an incident. You don't say of the patient smacking, slapping, hitting, kicking another patient. You're just going to say this resident was evaluated following notification of an incident involving another resident. And then you're going to put that note in there that says you were not present at the time of the event. That will come back on us when the survey team will be there or somebody is questioning you on what you know. What you don't want is for the nurses to have gotten something in your brain, or I was told, or they let me know, or even just avoid that and say, yeah, the patient was very violent last night. Well, you weren't there. That's secondhand or third-hand knowledge. So we don't want to put words in have people put words in our mouth, and we don't want to document inappropriately. So no acute injuries were identified on exam. So we're examining the patient. We weren't there at the time, but now we're doing an exam. The patient is alert, medically stable, and does not appear to be in distress. Current safety measures were reviewed with nursing staff. That might be, is the patient going to continue on one-on-one? The care plan will be updated. Not only is that a care plan in the patient's record at the facility, but we'll be updating our care plan when we do our assessment and plan. Our assessment versus our plan will be updated as needed to include support supervision, redirection, and environmental safety. So maybe our assessment and plan is aggression or agitation. And then some of our interventions would be continue one-on-one, have psych eval, continue supervision, redirect, staffing to redirect as able, and then no changes to current medication regimen. Maybe there are changes. Maybe this is where you get on the phone, you talk to behavioral health, you talk to your psychiatric mental health nurse practitioner, and they decide to start them on a mood stabilizer or another classification of medication. So the recipient, the one on the receiving end, so key charting elements, again, you're going to reaffirm that you were not present. You're going to focus on the safety, stability, and lack of injury. You're going to note their emotional or behavioral responses. So if you walk in and the patient is crying and they didn't know what they did to make someone so angry, that's what we're going to do, is note that behavioral response. Emphasize pain or no pain, any distress, whether additional support is needed. So that might be us going to the DON and asking if they can have psychology come in and meet with them for a couple of sessions so they can get through this. And then document follow-up plan that the care plan was reviewed or unchanged or modified. So maybe our chief complaint is an incident. Our HPI states that a patient was involved in an incident, and under our assessment and plan, maybe the patient has increased anxiety related to this. So that would be where we would come up with this documentation. So the resident, this would be your HPI, assessed following notification of involvement in last night's incident. Again, you're not going to spell out what the incident is. Whoever is reading this has to work to get this information. The nurse practitioner was not present at the time of the event. On evaluation, the patient is alert, calm, and not in acute distress. That's very, very important. In a jury in 3 years, they're going to say, oh, they couldn't function for 6 months and they lost weight or whatever. No, we want to note how they are after this happens. So they're alert, they're calm, they're not in any acute distress. No physical injuries. If there are, get x-rays, be on top of that to make sure that we're not letting something go longer than it needs to. Or behavioral changes are noted at this time. Resident denies pain or discomfort, care plan reviewed, and no immediate changes are indicated. Nursing staff will continue to provide supportive supervision. Here's another one. It's just that they were evaluated following notification of the incident. So you evaluated the patient, making sure that you're stating you were not present at the time of the event. On assessment, the patient is alert, medically stable, and does not appear to be in distress. Again, this is the receiver that we're documenting on, not the one that's doing it. No acute injuries. Nursing staff continue to monitor. No immediate changes. Maybe there was. Patient transferred to a different room per his request. It could be as simple as that. And then safety precautions remain in place. And maybe that's the other patient being one-on-one. But if there are safety precautions. So liability reducing tips. Remember, we're liable for what we document. We're liable for what we do and don't do in a crisis. So while this might not be a crisis, it is a reportable to the state, and we want to make sure that we've assessed the patient and that our documentation reflects that we looked at both the aggressor and the receiver on this. So never document what staff or other residents said unless quoting verbatim. Resident stated, he scared me. So you can't go in there and write, patient states that he's scared and intimidated and frightened. You're going to use direct quotes when quoting a patient. Use neutral terms like incident. I've told all of you before, we utilize the word incident. Let someone else do the work to figure out what that incident is. You weren't there. You didn't see it. All you know was what was reported to you, and all you're doing is documenting on the patient's status now, not on how it was last night, if he got beat up or if he beat someone up. You weren't there, and so you don't want second and third hand documentation in yours. Your note is your note. So neutral terms, incident or peer-to-peer interaction or altercation. So sometimes you can do an altercation. I always use for my chief complaint agitation or aggression. There is an ICD-10 that's violent behavior. I wasn't there. I don't know how violent it was. I don't know if they were just pushing him out of the way to get past. I don't know any of that. And so second and third hand knowledge, the nurses reporting and the patients reporting, I just don't know. So I'm not going to use that kind of language. Attack, assault, violence. I wouldn't use that kind of language either. Again, you didn't see it, you weren't there, and now you're getting a lot of different stories. Be cautious about using terms like agitated, combative, or aggressive. Use only if personally observed or part of existing diagnosis. So if they already have something like schizophrenia or bipolar with aggression or dementia with aggression, then we can use that. But for the aggressor, we need to have something as far as your ICD-10 code. So it could be agitation, or the aggressor could say, I was just trying to get through and he wouldn't move out of my way. And then don't speculate on the cause. Regardless of how well you know the patients, do not speculate. One person might be mean all the time, and that doesn't mean that that happened in this instance. So please be very careful on avoid speculation. This came up this morning, allegations of rape. This is to be taken very seriously, and this is a whole interdisciplinary effect that goes along with this. So when there is an allegation of a rape, involving a confused or cognitively impaired patient, someone with a BIMS of less than 11. It enters a medical legal zone that requires documentation. However, it has to be neutral, it has to be factual, and it has to be carefully worded to protect resident rights, the facility, and you as the provider. Because if you think about a sexual assault or a rape, it's not only a litigation, it's not only an ACA issue, but now it's a police investigation and potentially a felony or a misdemeanor, depending. So how we word this is very, very important. So here's a guide on how you must document, what should be left to the facility and law enforcement to document, and how we will protect our nursing license and mitigate risk of ACA, the Department of Health, and board scrutiny. Remember, the Department of Nursing is there to protect the public from nurses and nursing mistakes. So don't ever look at the Department of Nursing as being helpful to us, being able to answer questions for us. Same as the Department of Health. Their main goal is to protect the public. So we are trying to minimize the risk of litigation, Department of Health, Board of Nursing issues, and we do that within ourselves and not through them. So we are going to be undergoing scrutiny from these guys to make sure that we're protecting the public. Okay. So I put a red stop sign. This is immediate. I want this to be of immediate thought in your brain that someone has done an allegation of a rape. Now, maybe this person has done it every single week or every single time she gets a urinary tract infection. Maybe there's a long history of this going on in her past, and so now she's remembering it because the dementia is getting out of control. Does not matter. If it's an allegation, it's an allegation. So a sexual assault has to be taken seriously, even from a confused patient. Regardless of mental status, they could have a BIMS of 0. It triggers mandatory reporting, including ACA, Adult Protective Services, and law enforcement. And that's your DON and your administrator that will do that. So if you get wind of this before they do, it is an emergency for you to stop, drop, and pick up that phone and call your administrator or your DON. They need to know this. So what should you document if you are involved in a rape allegation? So meaning if there is a patient in your facility who reports that she was raped or he was raped, what is your liability for documentation? Well, you are required to document. You are the provider, and you need to, you don't have to substantiate, but you have to give information based on a medical exam on what you find. Now, again, other people are going to be doing it. The police are going to be doing it. The DON and administrator will be doing their investigation. Your investigation is of the patient themselves. So when you're documenting, you're always going to state that you were not a witness to it. You want the answer. It says nurse practitioner was not present at the time of the reported incident and is evaluating the resident following nursing staff report and clinical concern. So there's the answer. That's your first statement right out of the gate, is that you're doing an evaluation based on this, and first and foremost, I wasn't there. Do not use terms like rape or sexual assault unless reported by the resident in those exact terms. So you can say something like, resident made a statement suggestive of inappropriate contact. So patient standing out, there was some guy standing outside of my door and he dropped his britches, and I saw the whole thing. That's what the patient's going to report. Again, that is not anything that you would want to document on. You're going to write a statement of what the patient says, a potential inappropriate contact or viewing. Due to cognitive impairment, reliability of report is limited. Statement relayed by staff as followed. And so if there was something that the staff said, John Doe raped Jane Doe, however it was, you can put a statement by staff that that was what was said. But we don't want to utilize those words rape or sexual assault unless the resident used those terms. That man outside raped me. Then you can put those in quotes because that's what they said, not that's what you assumed happened or that's what you're thinking happened or any of that. So if it's by the resident in quotes. Resident verbalized concern regarding possible inappropriate contact due to cognitive status. Further clarification was not possible. So you can utilize words like that. Mental status and reliability. Be clear about the BIMS and the cognitive status. This impacts, will, can, and should, and always does impact the legal and medical response. So if you've got a patient that's alert and oriented to self only, they don't even have a BIMS. They don't know where they are. They don't know when it is. They don't know what year it is. They don't know the president. They have no short-term memory. Sock bed in blue, something they couldn't even fathom. That makes the difference. That needs to be documented on. Again, this is what the nurse should document. So be clear about their BIMS. So if they have moderate to severe dementia, they have a BIMS score of 3, and they're unable to provide consistent or reliable responses to questioning. There often are times when you come back the next day and you were told this and you're going to investigate with a patient, and you can ask them, can you tell me about last night? No. Did anything happen last night? No. Was anyone in your room last night? No. Did anyone touch you inappropriately? No. So what happens then may not be what they're able to recall then. So this would be where you would say that they have moderate to severe dementia. They're unable to provide consistent or reliable responses to questions. Patient does not recall any incident occurring from last night. And then your physical findings. So let's just say all of the above. You've got a patient, they're not alert, they're not oriented, and they said that, and now they can't remember they said that. Is that the end of the line? No, because they had made that statement. So we are responsible, the nurse practitioners and the general practitioner are responsible for documenting whether the patient has any physical signs of trauma. So you're definitely going to look at the external genitalia, the perineal region. You're looking for fingerprints. You're looking for bruising. You're looking for any swelling. You're looking for bleeding, any kind of trauma or distress. And you can even write, patient denies complaints of pain or discomfort at this time. You are not going to do any kind of internal investigation at that point. You do not start looking any deeper than what you can physically see. So that is your extent of the documentation. Even if there are no visible injuries, you're going to document that the patient was calm or cooperative on exam, no verbalizations of pain, no behavioral changes. And then you can state in there that facility leadership, APS, and law enforcement have been notified per mandatory reporting guidelines, incident to be investigated further by appropriate authorities, because you never want it to come back on why you didn't do a vaginal exam or a rape kit. This is what you're responsible for doing. This is what you document. This is what you perform. So your physical findings are only external. when you're evaluating a patient. Try not to use the word rape unless the patient continues to state they raped me. Don't state your opinion or truthfulness or validity of the report. Patient states, patient's alert and oriented ×3 and states she was raped, and I believe her because she sounds legit or whatever. Don't state your opinion. Patient is alert, confused, unable to remember yesterday. It's doubtful that any attack was ever had. Don't. That is not your job. Your job is to document point blank facts. That's it. Don't document nursing hearsay or other residents' involvement. Don't assign intent or culpability unless you're there to assess and support medically. And then don't note if someone is a known sexual aggressor. Leave that to the psych and the facility behavior plan. So if you say that the patient is currently receiving female hormone therapy related to a long history of sexual inappropriateness, that is not your responsibility. That falls onto psych. So again, just what you see, just what you're evaluating, just the facts. So an example for a documentation for the aggressor. So the nurse practitioner was consulted following staff report of resident making statements suggestive of inappropriate contact. Nurse practitioner, this is the most important thing you're going to do on this whole entire PowerPoint. Nurse practitioner was not present during the reported event. The resident has a known history of cognitive impairment. The BIMS is 3, and the patient is unable to provide a consistent account of events. Resident evaluated today and appears calm, cooperative, and in no acute distress. No verbalization of pain or discomfort. Genital and perineal exam unremarkable. No signs of trauma or physical injury noted. Facility administration, APS, law enforcement have been notified per protocol. Don't just write that. Make sure that you go to the DON and ask them, have we called the police? Have we called APS? And does your administrator know? So don't just write that as a blanket statement. Verify, trust, yet verify. We've all heard that term. Further investigation will be managed through appropriate channels, meaning you've done your portion. There's more to come. You've got other people working on it, but this, I'm done. I've done my evaluation for the patient. And you're going to continue to monitor for behavioral or physical changes, and the psychiatric team remains involved, obviously. So the nurse practitioner or the doctor's role, this means primary care. So primary care is very different than other roles in the facility, which one of them would be the psychiatric mental health nurse practitioner, who gets more involved in this. Do not try to take on their roles. So as the primary doctor, primary nurse practitioner, you are going to do a clinical exam. It's going to include a full skin check, assessing trauma, and documenting mental status. So any skin check, you want negatives, no bruising, no scratching, no trauma indicated. So when you're doing that, include that. Forensic investigation, no, that goes through the facility, law enforcement, and APS. Absolutely no forensic investigation. Documentation, you're going to chart facts only. Anything that you don't know that is reported to you goes in quotes. Avoid speculation. It appears that patient is confused. It appears patient has a urinary tract infection. Avoid those words at all cost. And then notification. Ensure that family, facility, and APS are notified. And maybe the facility has already notified the family. So you turning around and notifying the family, and then the police turning around and notifying the family, it's a lot. So only notify the family if the DON is asking you to. Make sure that someone has notified the family, but that does not have to be you, only if they're asking you to do it and appropriate. So here's just a checklist, a medical assessment template for alleged inappropriate contact. So the diagnosis of dementia is a yes or a no. BIM score is a 3, 4, 5, 6, whatever. If you don't know where to find it on the MDS. Patient verbalizes, I was raped, and then put that in quotes, or patient verbalization. I don't remember anything. What incident? In quote, what incident? I don't remember that happening. And then the reliability of statements, reliable, unreliable, unable to assess. So the patient's got a BIM score of 3. Their statement is they have no clue what incident I'm even talking about. So the question then becomes, with that statement, are they reliable? The behavior, are they calm? Are they agitated? Or are they in a fetal position, tearful, withdrawn? Or are they cooperative? And then any of the behavioral changes that are observed. You're going to do an exam, visual and non-invasive. I can't say that enough, non-invasive. You're only looking. So you're looking at their head and neck to make sure that there's no bruising, their upper extremities to make sure that there's no bruising, their abdomen to make sure there's no bruising, perineal area. You're looking for bruising, you're looking for bleeding, inner thighs, gluteal area, same thing, clothing and bedding observation. Now they may be incontinent, but they're always incontinent, so their bed is incontinent, but there's no blood there. Patient denies complaints of pain, yes or no. If they have pain, but it's in their left hip and they just had a left hip replacement 6 weeks ago, you can absolutely put pain, 6 out of 10, right hip only. Nonverbal signs of pain, where they noted, you get a copy of their vital signs, and then the supportive care only. So no invasive interventions performed. Forensic exam deferred to law enforcement. If law enforcement believes that, they will send them to the emergency room. And then we're going to monitor for their psychosocial well-being and make sure that they're stable. And then any lab work, if indicated. So if it's not indicated, we wouldn't do that. If the patient is usually a little bit more oriented, but is very, very, very confused, then you may want to get a CBC and a TSH and a urinalysis. Rule out infectious process, rule out thyroid process, and then we continue to move from there. This assessment does not confirm or refute allegations. All it is for us to collect that data. I actually have on a Word document this assessment, and I will upload it into TrueRCM so that you guys can download it anytime you need a blanket copy of this, or you can, of course, utilize this one. Again, it's not for the chart, it's for you to take information when you're doing your assessment. So where do I get all of this knowledge, and how do we know if we're doing it exactly how we're supposed to be to cover the facility, to cover our license? Well, first thing you do is you go under the CMS. It's that thick red book that gives nursing facilities their regulations, and there is an F tag for every regulation that you do not follow. So F600 indicates that a patient has a right to be free from abuse and neglect. So facilities must ensure residents are free from all types of abuse, implication. If there is one, it indicates a mandatory investigation, including a timely assessment by a nurse practitioner, PA, or MD. And then where do I find this information? Well, I found that in the CMS State Operations Manual. So that's that big red book. So the Department of Health and Human Services, the OIG, the Office of Inspector General, incidents of potential abuse and neglect at skilled nursing facilities were not always reported or investigated. That's another citation you can get. So nurse practitioners and physicians are advised to document objective findings promptly and accurately. Objective, only objective. That's what we're required to do. Medical personnel should avoid speculative language. And then you can go to the OIG link. The Elder Justice Act, which is part of the Affordable Care Act, mandates covered individuals, including nurse practitioners and MDs, of reasonable suspicion of crime within 2 hours if serious bodily harm is suspected, or 24 hours if not. So you can go onto the Department of Justice Elder website and get the information on that as well. Again, this is criteria we're required by law, we're required by the Board of Nursing to follow. You can go to the American Medical Directors Association. So it recommends that clinicians document the mental status of the resident, which I tried to include in our questionnaire, physical examination of findings, the resident's verbalizations, if any signs of trauma, and to report to the proper channels. We don't make conclusions. We don't make our thoughts to what actually happens. And the American Medical Directors Association emphasizes the role in our accumulating the data, the assessment, and not the investigation. We are not in charge of the investigation here. And then the National Center on Elders Abuse encourages clinicians to use non-leading questions, avoid conclusions like, oh yeah, that was abuse. You were definitely abused. So you don't want to reinforce that, and always refer and report even if the patient is cognitively impaired. So the patient's laying there, they're mostly sedated, maybe they're on pain medication and their dementia, and they're going, I'm getting raped, I'm getting raped. That's an allegation of abuse. So we follow that all the way through until we determine someone, not us, abuse or not abuse. And so this is the NCEA, the National Center of Elder Abuse. So the stuff that I bring you, this is not brandy information. This is directly from the top 5 most important abuse investigation for resident to resident and rape allegations. So if you have any questions, let me know. I will post this under True RCM. So you should have a copy of this. You should have a copy of the assessment form that you can utilize. And you could just put their name on the top and then just take notes on it. And this is how you would make your documentation. But any questions, please let me know. Please, if you want me to review your notes, let me know. I'm here for you. I'm here to help you get through this. And I appreciate your time in watching this today. And I hope you have an amazing day.